All right, good morning, gentlemen. I think after yesterday's late night session, we are now moving from thrombotic risk to bleeding risk. So I think Javed just very briefly spoke to you on the thrombotic risk, and I shall try to take you on this journey of bleeding risk. Now, just looking at the background, total knee arthroplasty, most commonly performed elective surgery worldwide. TKA provides significant pain relief and improvement in quality of life for many. However, TKA is not without its complications. Significant blood loss is sometimes, or maybe most times, requires blood transfusion. And bleeding during total knee arthroplasty may be either because they are hemophiliacs or anticoagulants, they may be on aspirin, or whether they have some cirrhosis. But besides everything else, I think the surgical technique is very important. And knowing where the bleedings are, especially the lateral geniculate vessel from the lateral retinaculum and also the PCL branch. For those who are doing the CR, you probably don't see so much of the PCL bleeding, but those of us doing the PS, I think we always see the PCL bleeding. Now, transfusion. The transfusion rate in TKA is about 30% worldwide. Transfusion-associated risks, as we all know, are infection, acute systemic reactions, and death. Transfusion normally increases rehabilitation time. That means lengthening hospital stay. Hospital stay lengthening means it's cost to the patient. And controlling blood loss during and after surgery is an important goal in achieving the good results in TKA. And tranexamic acid during TKA in surgery is something that I'm going to talk about. Now, I think this is a good slide because Javed is here and it's from his place. This was described by Rasoli and all. And blood management and after total knee arthroplasty in the United States, a 19-year trend analysis showed that there was a worrying trend of blood transfusion post-TKA. That's how the pathophysiology works. The tranexamic acid is a lysine analog. It's an inhibitor of the fibrinolysis. IV tranexamic injection is efficacious in controlling blood loss. It reduces the transfusion requirement. The dose that I use, or rather it's been recommended, is 10 milligrams per kg body weight, or otherwise 1 gram per dose. Tranexamic acid inhibits the plasminogen activation, and the plasmin cleaves the fibrin clots right there over the, and into the degradation products, and it allows the clots to dissolve. So therefore, inhibiting the conversion of plasminogen to plasmin, tranexamic acid allows mature fibrin clots. Coagulation will continue uninhibited, and the IV tranexamic acid has a short life of 2 to 3 hours, and it has renal clearance. So people with renal failure, you've got to be a little bit careful. Benoni and I think was one of the first people to describe on the pathway of tranexamic acid. Now, these are the concerns. The concerns are thrombosis, pulmonary embolism, renal failure, and epilepsy. Now, that's a dry field in surgery. I don't normally use a tourniquet, but anyway, these are some of the studies that are in favor of us of using tranexamic acid, starting from Shandong, Cochrane study, and I like the Wu and all on the reduction of blood loss and transfusion. But also, if you look at the bottom line on the culture and all, on a retrospective study published in 2017 on the incidence of seizures, and it is known to cross the blood-brain barrier, so something to think about, especially those with epilepsy. This is my observation from 85 patients in the last 2 years. I excluded all the high-risk patients. 20 standard that without tranexamic acid, and 65 had tranexamic acid. Female-male ratio of 3:2. An average age of 62.2. Comorbids were all taken into consideration. I gave 1 gram of tranexamic acid on skin and 1 gram on releasing of tourniquet. I only put the tourniquet on during cementing, which is about 15 minutes. The average blood loss for those without tranexamic acid was about 833, and those with tranexamic acid 428. Now, 86% of those in the tranexamic group and 36% in the placebo group did not require the autologous blood transfusion or allogenic blood transfusion. The mean transfusion amount was 273 mils. Now, in the tranexamic group, the blood loss was 428. There was a hemoglobin drop of 10 to 25 grams per liter. Patients who received tranexamic acid had a lower amount of blood loss, statistically significant, and the rate of transfusion was statistically low in the tranexamic group. As opposed to the non-tranexamic group, which is a smaller group, the blood loss was about 833 with a hemoglobin drop of 20 to 50 and an RBC transfusion rate of 10 to 69%, and they needed blood transfusion. Now, with that, we come to the transfusion risk. Disease of transfusion during transmission. During transfusion reactions, clerical errors can sometimes happen because, especially for those of us in private hospitals, we may not have doctors, either we got to get the nurses to actually look at the blood, and we have infection and myths, especially those from a particular sect of groups, especially a certain sect of group. We'll not get into that. Now, transfusion effects can sometimes cause poor quality or the hemoglobin and reduce the oxygen content, and increase the length of the stay and increase the cost to the patient. To discuss, Kenneth and Pagano in 2013, they said that to avoid tranexamic acid for people who have had past histories of VTE, an embolic CVA, and recent coronary stent. Likewise, prophylactic intravenous administration of tranexamic acid lessens the amount of bleeding in the endoprostatic knee. It reduces the likelihood of blood transfusion. Tranexamic acid should not, I repeat, should not be given to patients who have recently had urogenital bleeding, pulmonary embolism, myocardial infarction, recently undergone percutaneous transluminal coronary angioplasty or stenting, and those who have been known to have epilepsy. There are a couple of meta-analyses that have been done. I think you can read it up. And these are some of the interesting meta-analyses that are in favor of tranexamic acid. And in conclusion, based on the current evidence, I think from my observation, I find it safe. Tranexamic acid can help actually reduce the need for transfusion. It reduces the total blood loss, and there's no occurrence of DVT in all the 65 cases, and the administration and recommendation are routinely in bilateral TKA or unilateral TKA. And tranexamic acid reduces blood loss and the need for transfusion without increasing the occurrence of DVT. And I think it also helps to reduce pain. And with that, I'd like to thank you very much.